Objectives, I won't go through too closely. I'm sure you can read them off, but just really looking at the impact of smoking across the lifespan of women, looking at optimal evidence-based tobacco cessation and reduction strategies for working with women across the lifespan, determining whether or not to recommend pharmacotherapy for women seeking to quit or reduce during pregnancy or breastfeeding, and to talk briefly about support. Okay, how do I switch? Thanks. Okay, so I'm going to start out with a question for you all. Now I know we're webinar based, so we'll have to ask participants to type this in, but what's the first thing that comes to mind when you think about why women or young women today, particularly, why do they start smoking? So we'll see how fast everyone can type. Oh yeah, so we have a lot. So it's weight gain, staying slim, peer pressure, socialization, looking cool, looking sophisticated, social lubricant as a way to connect or disconnect with people, peer pressure is big, stress, modeling, fitting in, all of the above, experimentation. That's a key point too, that I haven't met any young person, and typically I work with older people, men and women, not older, but middle-aged. The average age in the clinic is 48 of the clients that we see. But when they look back on their youth and the first cigarettes they tried, nobody had this intention of becoming addicted to smoking. Coping mechanisms, relieving stress, self-medication, mental health. Okay, I think we have almost all of them. Let's see what the survey says. And if this was Family Feud, a lot of you would get maximum points for controlling weight, fear of weight gain. Body image issues are huge for women and men too, but especially women. Concurrent mental health issues, so that theory of managing stress as a social lubricant, social anxiety, perhaps self-medicating depression. And again, if we look at the research out there, it's sort of the chicken and egg argument. There's an abundance of research supporting that. It's a self-medication hypothesis, that it's a way to alleviate depressive symptoms, perhaps that's not diagnosed. Or there's also an abundance of research that shows that looking at youth who smoke and comparing large groups of youth who don't smoke and the onset of depressive symptoms later on, and the youth who smoke have higher rates of depression. Trauma. Another great point. So we know that women who experience at least 2 episodes of child abuse before the age of 17 are 3 times more likely to smoke. Coping with stress, fitting in peer pressure, again, that's huge. Fashion and style. Another key point, so not just with the weight gain, but if you look at what's going on in music videos, in movies, in magazines, especially American magazines, where there can still be, or the internet, where you can see pictures of celebrities who smoke, perhaps, idols, in terms of people that the teens look up to, young women. Marketing and tobacco industry marketing is huge. Targeting women. So really, this is another way to look at all of those factors, just grouping them more broadly. Looking at socioeconomic status, we know that, again, women with less education levels and who are more economically deprived, lower socioeconomic status, are more likely to smoke and have higher smoking rates. Childhood abuse, again, I mentioned that those incidences of childhood abuse before the age of 17, just even 2 isolated incidences, increase a woman's likelihood that she smokes by 3 times. Education, single motherhood, young motherhood, and where they live. Again, so there's disparities across the population in terms of who's smoking and who's most affected by smoking and who has the most access to treatment. So there's a lot of arguments to acknowledge that when we're looking at maternal smoking and women who are pregnant and postpartum, we should especially target those areas where they're dealing with more economically and socially deprived women, because there's a disparity in how much those women are affected by their smoking. So, if we look at a broad picture of the smoking environment in Canada based on the CTUM's 2011 data, or 2012 data, sorry, approximately 14% of Canadian women over the age of 25 smoke, are current or daily smokers. And again, this is a really rough estimate. It's hard to get accurate numbers. And again, if we group this into special populations or different populations, for example, if we took a look at Indigenous populations or groups of Métis women or other First Nation women, the smoking rates would be much higher. If we looked at women who also were struggling with addictions or concurrent disorders, again, the rates would be higher. But generally speaking, approximately 14% of Canadian women smoke. Another number that's really hard to get an accurate read on is 10.3% of Canadian women of childbearing age smoked during their most recent pregnancy. Now again, because of stigma, we can err on the side of underreporting. If we look at socioeconomic status, those are the women who are showing up for prenatal care. So there's a lot of women who are being missed by this. Also, there's women who will spontaneously quit in the first trimester because it's too aversive to smoke. They feel unwell, or they're able to quit. The body naturally rejects it and makes it easy for them to quit smoking. And they don't necessarily report the fact that they were smoking earlier on in the pregnancy or before they knew they were pregnant at the time. So again, estimates of tobacco use among pregnant women range anywhere from just under 5% to 23%, and that's a very approximate number and looks very different depending on where you go in the country and what group of women that you're looking at. So if we take another look at sort of the impact of impact of smoking across the lifespan for women, and again, a broad picture, and we look at the mortality. So every 35 minutes, a Canadian woman dies as a result of smoking. So that's roughly 43 women per day. And since the tobacco industry has co-opted the women's movement, and since we've come a long way, baby, has made a huge impact on women, that equalization of women's rights and the increase of women smoking has led, unfortunately, to an increase in women's mortality. So there's been a 600% increase in lung cancer deaths in women since 1950, and it kills more women than breast cancer. And then if you think about it, there's no, the pink ribbon campaign, the importance of mammograms, all the publicity and the knowledge and public awareness of breast cancer these days is fabulous. But smoking and lung cancer and the impact of smoking on women's mortality really flies under the radar. Even issues like, addiction, Mothers Against Drunk Driving. That campaign has a lot of notoriety, but you don't see marches or campaigns for women against, tobacco or with lung cancer. We know that heart disease kills 4 in 10 Canadian women, and for women, smoking triples that risk of dying from heart disease. It also is associated with increased risk of early or natural menopause and fertility difficulties. In terms of impact on pregnancy, and I'm sure many of you know these, are well aware of these risks already. So there's an increased risk of vaginal bleeding, premature delivery, an increased risk of spontaneous abortion, and that's even just with under 10 cigarettes per day, and a 20% increase in perinatal mortality if the woman smokes more than a small pack a day or 20 cigarettes per day. There's 1.8 to 2.4 times greater risk of having a low birth weight baby. And there's also, if we look at the 2006 U.S. Surgeon General's report, there's suggestive evidence, or what they would categorize as level 2 evidence, that there's also a risk of childhood cancer. There's problems with the membranes rupturing, so a risk of 1.6 to 2.8 times greater risk of developing abruption placenta and placenta previa, premature separation of the placenta from the uterus, or where the placenta covers the cervix or moving up or away from the uterus, so problems during delivery, which puts both the mother and the baby at risk. And it can also impact breastfeeding. So there's an association with less duration, frequency of breastfeeding, more difficulty breastfeeding, and an impact on the quality of the milk. Reduction of supply of milk by 30%. There's also maternal smoking has been linked to colicky symptoms, essentially, in infants, and the jury is out on this. There's disagreement as this was due to cigarette smoke. We don't think it's due to nicotine because there's no withdrawal symptoms from a stimulant. Nicotine is a stimulant, but some studies have shown that there has been an association between colic and smoke exposure. So if we also look at the impact of secondhand smoke on children, there's an increase in SIDS, or sudden infant death syndrome. And that's not just if there's maternal smoking, but there's been studies that have shown with paternal smoking, if the father smokes, that the risk is significant. There is a British study, trying to see if I have the name here, a British study looking at lung tissue concentration of nicotine in sudden infant death syndrome, and from McMartin and Platt, and it concluded that SIDS death could be reduced by 2/3 if the parents did not smoke. And that's from, actually it's from 1996, it's older, and there's another one, Peter Blair et al., Smoking in the Sudden Infant Death Syndrome, looking at deaths from 1993 to 1995. We also know that in terms of childhood asthma, asthma is more severe in infants and young children when they're exposed to secondhand smoke, and the risk of middle ear infections and lower respiratory infections. Girls are at greater risk of decreased lung capacity function. So again, if we look at this from a gender-specific point of view, the impact on young women and girls and females is different than men. Also looking at the impact of breast cancer later on, there's an association between exposure to secondhand smoke and increased risk for young women and developing breast cancer later on in life, not just if they smoke themselves. So if we look at the impact of secondhand smoke on teens and things, also factors that lead to their daily smoking at ages 18 and 19, and we know that approximately 80% of all young people will make the decision to have their first cigarette or start smoking under the age of 18, so as children or young adults. The factors that are leading to that decision are part of that decision are weight concerns, so a desire to be thin and fit in, again, points that you've already mentioned with the first question. Poor conduct, so that if there's an association with that as a component or a risk factor, stress, and having one parent, a single parent family. And those are, if we look at the factors or look at those young women at ages 11 and 12. Again, a time when a lot of young people will start to experiment with tobacco. So we know that girls 13 and older reach puberty late because of drinking or smoking, so the impact of smoking can affect the onset of puberty. They might not grow as tall, bones might not become as strong, and it affects the absorption of vitamin C and vitamin D in young women. Early use of alcohol or tobacco could disrupt the hormones. We know that if we look at that self-medicating hypothesis, or as a component of what leads to smoking or what maintains smoking, smoking can help with hormonal changes that cause mood fluctuations. So a young woman might find out early on that it helps regulate her mood. Again, nicotine works where the other drugs work in the brain, on the pleasure centers. So it's a way to a coping strategy for many people for anger, depression, or mood swings. Contraception. So again, if a woman is smoking, this can impact her reproductive or oral contraceptive choices because of the increased of risk of stroke and arterial sclerosis if she's smoking and using oral contraceptives, and risk of heart disease. So it's important that not only the physician or the nurse prescribing the oral contraceptives has a discussion with the woman who wants to take them about the pros and cons, the risks and benefits of using this medication when smoking, but also that's an opportunity to put on the table, have you ever explored or considered quitting or reducing? How do you feel about your smoking? Rather than just talking about the risks and benefits. Again, so there's an impact on women's hormonal patterns if she smokes. There's an increased risk for painful and irregular menstruation and reduced fertility. Women who smoke tend to have earlier menopause. Also, females born to women who are smoking tend to reach menopause earlier, 1 to 4 years earlier. This is because of the destruction of about a quarter of the eggs at birth, and that's required to see a 2-year advance in the age of menopause. So basically, young women who are born to moms who smoked are born with fewer eggs. Fewer years with protective effects of ovarian hormones, and may experience more menopausal symptoms. And again, there's lower bone density and increased risk of osteoporosis for females who smoke because, again, the absorption of vitamin D is impacted. So women who smoke tend to need more. Sometimes heavy smokers double the amount of vitamin D as a woman who doesn't smoke to help protect her against developing osteoporosis later on in life. So if we look at some cessation and reduction strategies, what we're advocating for is a woman-centered approach. And so when I say woman-centered approach, and I'm sure, again, many of you are familiar or actively using this approach, what does that mean to you? And the slide's right in front of you, so you could, even if you're not familiar with this term, you can type something in if you're so inclined. So lots of great comments. I could just sit here and read them, talking about the menopause and people's personal experience. Kathy writes that it's a collaborative approach, client-driven, yes, versus a paternalistic approach where it's more directive, expert-driven. Feminist-based awareness of social determinants of health, woman positive. Thank you, Catherine Wallace. Linda also nails it very concisely, not focusing on the baby's health. So really looking beyond if the woman's pregnant, looking beyond the fetus and the impact of her smoking on the fetus, but taking that whole picture of the woman, getting a sense of how smoking fits into the rest of her life, what her socioeconomic status is like, her education, employment, is there trauma history, nutrition, stress, coping mechanisms, social issues, family and support, and really getting a sense of how smoking fits in, what it does for the woman, what's good about it, what's bad about it, and looking at her beyond just the fetus and the duration of the pregnancy. Heather said it really nicely, the overall picture for the woman, not just the baby, and looking at her across the entire lifespan. So this is just a key thing, a consideration to keep in mind when developing a treatment plan or tailoring treatment plan for women, that women tend to form their identities in connection with other women. And women tend to be healthier and happier when they can nurture themselves and not when they're isolated. So groups can go a long way, and social support can have a really significant impact on women and pregnant women and postpartum women as a way of connecting and forming their identity or reshaping their identity, which is often part of that quit process, reinventing themselves, envisioning themselves as a non-smoker and what that look and feels like, and doing that in collaboration with other women can be very, very helpful. Society often values independence, whereas women benefit by connecting with others. So these slides just speak to the importance of not just what we say, but how we say it. And again, that key component of just developing therapeutic alliance with the women that we're working with, establishing a connection, and engaging. So there's so many ways that you could ask or put the discussion of smoking and tobacco use on the table. And this is just asking us to take a step back and consider how we go about having this conversation. So again, not just tone of voice, but even the words that we use or the timing of when we decide to have this conversation or try to explore this issue can really either solidify the relationship, or it could rupture the relationship if the woman doesn't feel safe, or she feels judged, or she's just not sure yet. The trust and the connection isn't quite there yet, or perhaps she's had a negative experience somewhere else, either in her family or in the community, and felt shame and excessive guilt about the fact that she's smoking and pregnant. Again, so, with the denormalization of smoking in those campaigns to increase awareness and tackle the tobacco industry and their marketing over the years, that has an impact on one of the unintended consequences is the denormalization of our clients. And then when you take into consideration that the women we work with might be pregnant or visibly pregnant, there's a double stigma, almost a double dose of guilt and shame on top of that. So this conversation can be delicate. It might not be. Oftentimes I work with women who are really keen to quit smoking or want help and have been actively trying but not able to. Very recently I had a woman come in who was just in her second trimester, about 20 weeks pregnant, and when I was doing her assessment, she was talking about her obstetrician and how he asked about her smoking, and she said she smoked, and he mentioned that she should quit, and she said she was trying, and then that was it. And she's like, shouldn't he be more worried about me? Like, I want help quitting. I'm freaking out over the fact that I'm smoking, and I'm getting bigger and bigger, and I thought I would never be pregnant and smoke, and I'm still smoking, and the longer, the further the pregnancy progresses, the more stressed out I get. And so for her, she wanted it raised on the table, or more than just, are you smoking? Yes, no. Okay, try your best or try to quit. She wanted to have more of a discussion about it. And again, in this case, and this is just one case, she felt that she wished more had been done or offered. And so she actually self-referred to our clinic. At the same time, there can be so many other issues and stresses on challenging issues on the plate for the women that we work with. Often pregnancy is just one part of the puzzle that smoking might not be on the radar. They might be dealing with finances or support or relationship problems, violence, dealing with other kids, legal problems. And this is sort of the last thing on their radar in terms of their priorities. So, think about, how you ask and how can you put this conversation on the table respectfully in a way where the woman feels safe to talk about it and also doesn't feel like she's going to be forced to take action or not, but just lay it on the table. Would you mind if we talked about your tobacco use? Or could you tell me about your tobacco use in the last 6 months? That's very different than, are you a smoker? How much do you smoke? Again, I tend to prefer the open-ended questions because it gives me more information. If the client is willing, they can tell me as much as they want rather than yes or no. But again, it's about just taking a step back and considering how we go there. One of the tools that I find really helpful in using is something called a readiness ruler or confidence ruler. And it's a linear tool. It's coming up on one of the slides up here. And it's a way to sort of gauge somebody's how they view the importance of quitting smoking or reducing smoking in the moment, and how they view their self-efficacy. So you can use a scale of 0 to 10 or 1 to 10. It doesn't really matter. It's a matter of preference. And using the scale, if 0 isn't important at all and 10 is extremely important, quitting smoking is the most important thing on your plate, I find it helpful to ask the vast majority of people I work with, in this moment, how important to you is it to quit smoking? And oftentimes I'll get a high number. I might get a 9 or 10 or 11 or an 8. And then I'm not so interested in the number, but I'm interested in the conversation around that number. Okay, so it's very, say somebody gives me an 8. So it sounds very important to you. Tell me about that. What's bothering you? What concerns you? And that's really helpful to know, to get a sense of the person's priorities and their point of view and their values and their needs. At the same time, it's helpful to explore confidence with the same ruler. Again, on a scale of 0 to 10, if 0 is you have absolutely no confidence at all in your ability to make any changes to your smoking, and 10 is you're sure you could quit if you wanted to, you're fully confident this could happen if you set your mind to it, how confident are you? And again, a broad generalization is I'll often get numbers high in importance and lower in confidence or self-efficacy, where somebody might give me an 8 or 9 and in importance, but they might give me like a 2 or 4 in self-confidence. Well, it's extremely important for me to quit. I know I wanted to quit even before I found out I was pregnant, but now the pregnancy makes it more urgent, and my obstetrician wants me to quit, my family wants me to quit, my partner wants me to quit. I want to do it also, but I've got to tell you, I've tried like 6 times before and I was never successful. And I'm so stressed out, and this pregnancy wasn't planned. I can't believe, that I'm still smoking now, and I'm trying my best not to, and I can't make any changes. I'm stuck. So I have very little confidence. And depending on how somebody answers, if they're high in importance and low in confidence, that gives me some information to use. It's about building hope and helping them see the possibility of change. That can go a long way to either them reducing or quitting, or just at least making an attempt, keeping that on the table, versus somebody who says, well, you know what, actually, I've got so much else going on right now. My partner's in jail. My employer doesn't know I'm pregnant, and I'm in a new job, and I'm worried that if they find out I'm pregnant, I've been there less than 3 months, I'm just going to get fired, and I won't have any benefits. And I've got no housing right now. I'm staying with friends. This is like the least of my problems. But if I wanted to quit smoking, I'm sure I could. I'm a 9. That's a very different scenario and conversation and treatment plan for that woman where this topic is low in importance, but she's high in confidence, than the woman who is low in self-efficacy but high in importance. Again, it's a linear tool, so I find it really useful. It's something that, again, isn't fitting with a motivational interviewing approach, but even if you don't use that approach, you might find the tool helpful. A caveat is that in some populations, so for example, if you're working with First Nations communities and working with somebody who has a holistic traditional view of healing and medicine wheel approach, this linear form of thinking might not be helpful. But generally speaking, I find this conversation evoking and getting a sense of how important this issue is and how confident someone feels to be a pretty helpful conversation to have in terms of developing a treatment plan or where we want to take this conversation. So these slides just walk through those questions, which I've been rambling about. So how we rate, if 1 is no confidence at all or 0 and 10 is very confident, how confident are you that you can quit? And really it's about when you hear those answers about what makes somebody confident or why this is an important issue, it's about listening for their values and a sense of internal motivation. How intrinsically motivated is this person to quit smoking versus how externally motivated is this person to quit smoking? Is it just because their family members or a partner or physicians or healthcare professionals are breathing down their back, or a sense of public shame and guilt that they want to quit? Or is it something that they want for other reasons, for their own health, to be the best mom that they can be, and they feel that this is an important part of that, to model healthy behavior for longevity, to be able to have energy to run and play with their kids, because it's affecting their health, and they want to feel better, or they've already got a diagnosis or they're worried of getting one. So getting a sense of how internal is this, the reasons for changing, and how external are they motivated. And again, if we look at the research, we know that people with higher levels of internal motivation are more likely to maintain abstinence for a year or more than people who are externally motivated. And if they are externally motivated, because oftentimes pregnancy is that foot in the door, that might be the reason that they're willing to have this conversation with you right now. They had never considered quitting before, and perhaps if pregnancy is unplanned. Again, as long as we're having this conversation, their reasons for changing might switch down the road. Or you might be able to provide them some information that they hadn't considered before that helps them move from external to internal or intrinsic motivation. So again, the goal is to create an identity shift and to tap into intrinsic motivation if it's not there already. Again, it's helpful to get a sense of that whole woman. So what's going on in her life? What is good about her smoking? What's not so good? How is it connected to her socioeconomic status? And again, for a lot of women, especially single women or women in poverty, they're dealing with smoking has a lot of concrete, serves a purpose for them in terms of they're not as hungry when they smoke. Nicotine's an appetite suppressant. They can afford to feed their kids if they're smoking, or they can give their kids more food because if they smoke a few cigarettes, they're not as hungry. It might be that it's how they deal with stress or manage their anger, perhaps. It might be, I had a woman years ago who, it was a way that she prevented violence, that she said sometimes before her partner hit her and he was going into a rage, she could offer him a cigarette, and that would be enough of a pause for her to have a cigarette with him, get her stuff, and leave before it escalated into violence. So it was a really protective mechanism for her, and a really hard thing for her to consider living without, even after she left her partner. It was this association of the one thing that kept her safe. So how is this helping the woman? How does it fit into her life? And what are the challenges in giving this up? Or what else do we need? What other coping strategies do we need so that the void is filled if she feels like leaving the void? Partner support. So just to quickly touch on this, again, to flag, let's be aware of our assumptions about partners, because there may be a partner, they may not be a partner. The partner might be male, but the partner might be female. And there might not be a partner at all. The pregnancy might be planned, might be unplanned. It might be unplanned, but received as happy news and welcome. It might be unplanned, but because of the person's religious beliefs or other values, they feel they really have no option other than to go through with the pregnancy, but have mixed feelings about, or are undecided even if they will keep the baby once it's born. It could be a highly stressful time. We know that partner support has huge benefits for women when they're quitting smoking or trying to reduce or quit. That perceived support, even if a woman perceives support, she's more likely to, high levels of perceived support for men and women are associated with increased abstinence, long-term abstinence rates. And a lack of support can contribute to a woman's relapse. So one of the biggest barriers that a woman can face, even if she's highly motivated to quit smoking, is if she's living with other people who smoke and there's smoking in her home. If she's able to live with other people who smoke but make the home smoke free, even if those people, roommates, partners, family, don't change their smoking status, that will more than double her chances of having a successful quit attempt. So that sense of, regardless of the motivation, which is important, environment is also important, and partner support. So smoking can be a source of conflict among families. Quitting or not quitting can increase the conflict. Again, if the woman's pregnant, she might be getting a lot more external pressure from friends, family, the public, professionals to quit or reduce. But it's also a way to connect and disconnect with people. If she has a partner and they smoke or they smoke together, this might have drastic ramifications on how they connect in their relationship. And again, pregnancy is a time where her relationship and identity are changing, the roles are changing, and this can add to the complicating factors. And we also know that women who are pregnant are at increased risk for violence. So depending on the power dynamics of the couple, we have to consider her safety as well. So we want to have, ideally, her in a home where there's no smoking. Support, the more support, the better, whether that be from family, friends, or a partner, or all of the above. But we also want to make sure that she's safe and get a sense of what that relationship is like. And if her and her partner both decide to quit smoking in support of each other, again, the research suggests a de-linked approach. So if we look at the research out of the UBC, there's so much wonderful research and resources coming out of UBC around women and fathers and partners and quitting smoking. They're advocating for a de-linked approach. So really working on helping the woman with her intrinsic motivation, her goals, and tailoring her treatment plan, helping the partner as well, acknowledging that they both can support each other, but really treating them as separate entities, not as necessarily a couple. At the end of the day, it also comes down to the woman's preference, what she thinks will be helpful, what she wants and needs. So again, once the sense of safety and the dynamics of the relationship is established, or you have a sense of what's going on, it might be that her and her partner do opt for counseling together. So again, not a simple answer, it's complex, but there's really no cookie cutter approach to this. So recommendations are really just exploring the relationship with a partner and how that will change. What's the power dynamic like? Is she able to ask that her home be smoke-free? Again, I have a couple of women right now who are pregnant or planning to be pregnant. One comes to mind, and she's in dire financial circumstances and has moved in with her mom and her mom's boyfriend in the home, and they're both heavy smokers, and she doesn't feel she's able to ask them not to smoke. I mean, it's not her home, and they're doing her a favor. She's essentially, her partner is in jail. She's got nowhere to go, very limited income. She doesn't plan on staying there, and she doesn't even want to go there in terms of having this conversation. Versus another woman I have right now who's got a partner. They're actively trying to become pregnant at a fertility clinic, and they both are highly intrinsically motivated to quit, and they're advocating, or they requested separate treatment, not to be treated together. They know they want to support each other, but regardless of how the other person's treatment plan evolves, my client wants to quit, regardless if her partner is able to or not. So if we look at pharmacotherapy and NRT and what happens, in terms of behavioral interventions and medical interventions, what does that look like? So we know that nicotine is harmful for the fetus. It's a neurotetragen. But it's also just one piece of the puzzle. So nicotine is one component of the cigarette, but it's also the other 3,999 chemicals in the smoke that concern us and have an impact on the fetus and the growth of the fetus. So what do we do? Our generous success rate would be to say, suppose we're able to help 30% of the pregnant women we see quit smoking. What do we do with the other 70%? If we look at this with a harm reduction lens. So again, we're taking a harm reduction stance, a collaborative approach versus a paternalistic, expert-driven quit or die model, and looking at the goals of treatment. For those women who are unable to quit smoking, and again, an estimate, if we look at stuff out of UBC and a paper I was reading where they quoted Lorraine Greaves, about 25% of women are able to quit spontaneously in the first trimester, are just able to quit. They find smoking aversive. What do we do with those other women who are unable to quit, are struggling to quit? Perhaps they're not even willing to entertain the idea of quitting completely, but is there a way we can help them, knowing that there's harms? There's no safe level of smoking. There's no safe level of exposure to secondhand smoke for both the woman and the fetus. What do we do? And at the end of the day, it comes down to the woman's goals. What does she want? What does she need? Versus idealistically, it would be nice if everybody that we worked with would be able to quit smoking. But the reality is, we can't make people quit, and not everybody will share that goal in the moment that we work with them. Perhaps down the road, quitting is a process, life is dynamic, things change, but not necessarily everybody we see will be on the same page with us if we flag this as a priority. So at the end of the day, it's the woman's goals who matter. And although abstinence is the healthiest choice, let's talk about the benefits of reducing if abstinence isn't an option or possible in the moment. So again, talking about behavioral strategies, and sometimes we'll flag, well, would it be possible to have an experimental quit day or 24-hour period? Sometimes women I work with don't think quitting completely or forever is feasible, but they'll be willing to try an experimental day, and sometimes the day is too long, even an afternoon or a period of time where they can see what it's like without smoking. Or just reduce the amount of areas that they smoke. If they're smoking in their home in every room, are they willing to make a plan where they make a room smoke-free and perhaps gradually work towards a goal of making the entire home smoke-free, but tackling it room by room? Or the car. If they have a car, that's another option. So really, in the first part, and looking at their behavior, helping them increase their awareness of their smoking so it's less automatic, it becomes more conscious, encouraging the woman to stop multitasking in smoking, but to start to isolate smoking and smoking just for the sake of smoking, not smoking and enjoying a coffee or a tea or sitting in your favorite chair or having a conversation with someone, but really just smoking and thinking about it. What's good about it? Do you really need this cigarette? Is this enjoyable? Is this what you want? Think about aversive thoughts. Sometimes that's helpful for women to do, especially when they're pregnant. Again, a generalization is a lot of women are highly motivated to quit because they know it's not ideal for the health of the fetus. So again, increasing awareness, making smoking more conscious, and helping them reduce the number of cigarettes they smoke per day. And sometimes even just reducing one cigarette per day or a few cigarettes per day can go a long way to boosting their self-confidence and self-efficacy. And so that idea of quitting completely maybe becomes more feasible, or they have more hope. And it's not that it wasn't something they wanted, it's just that they never thought it was possible. Again, for those women who don't feel that it's important, who say, well, my mom smoked through her entire pregnancy with me and my siblings, and we're fine. Like, this is the least of my problems. That might not have as much of an impact, but it might, depending, again, on the information this woman has and the conversations you have. Sometimes there's information people aren't aware of. And again, as long as you're having this feedback and information session in a respectful, neutral manner, the woman can be open to hearing it. And then at least, again, she might not quit or reduce or have the same goals as you, but at least she's having a conversation and you're putting it on the table. And at the end of the day, what you really want is her to be engaged in treatment. And maybe it won't impact her smoking, but maybe there's other areas of her life that you can help her with in terms of stress reduction or healthy eating or exercise, doing other things that will benefit not just her, but also the fetus, and healthy behaviors that she can adopt and practice and carry on beyond the duration of the pregnancy. So we talked about making changes in the environment. I'm getting all these stickies about how slow I'm going here. Talked about the importance of engagement. Really a measure of success is not the number of quits you have in the women that you work with or how many cigarettes people have reduced, but is she coming back? Does she find working with you helpful? Is she willing to keep entertaining this change conversation? That's a huge measure of success. So if we look at nicotine and nicotine levels and plasma doses, we know that heavy smokers, even when they're not smoking at night, there's impact to the fetus throughout the night. And again, at the end of the day, we're talking about, if we're comparing nicotine replacement to smoking, we're talking about one chemical which again, it's not without risks, but we're talking 1 versus 4,000 chemicals, or another 3,999. So it comes down to a harm reduction model. If we talk about nicotine replacement, one of the benefits is that there's no carbon monoxide. Carbon monoxide is attaching to the hemoglobin of the blood in the fetus, and that's being transported. It's impacting the amount of oxygen the fetus is getting. The heart rate and blood pressure also increasing, and that's not ideal. So again, if we can get nicotine, which is, again, the ideal situation is for her to be able to quit with behavioral interventions and no nicotine replacement therapy. But if that doesn't succeed, then it's a conversation about using 1 chemical versus 4,000. And a cleaner delivery system of nicotine. So nicotine without the smoke. When to recommend NRT. So the key point on here that Peter Selby always emphasizes is that the woman should be smoking more than 10 cigarettes per day. Nicotine replacement is also not offered in the first trimester in this clinic. Again, oftentimes we don't see women in the first trimester, especially if the pregnancy is unplanned. But the first line is always behavioral interventions. We also know that about 25% of pregnancies will end in miscarriage in the first trimester. So if the woman happens to be using nicotine replacement therapy at the time, it's human tendency to look at sort of what you're doing to lead to the miscarriage, and it will get blamed on the NRT. But again, so the first line of approach, and if we look at the clinical guidelines at www.canadapt.net, will be behavioral interventions. Again, if the woman's still unable to quit smoking more than 10 cigarettes per day in the second trimester, then a conversation about the pros and cons of using NRT is warranted between the physician or the nurse. Again, the goal is to use the lowest effective dose possible. And short-acting NRT, so the gum and the lozenge, the inhaler, the mist, is preferable to long-acting NRT because the patch is supplying a slow, steady dose. And so if we can have breaks where the baby isn't getting a dose of nicotine throughout the day, that's ideal. Again, that's not to say that there's some situations where a physician might recommend or have the woman consider using a patch for 24 hours a day. If she's a very, very heavy smoker and behavioral strategies have failed, intermittent dosing has failed, perhaps she's smoking more than 20 cigarettes a day. It's not to say that that never happens, but again, the first line of approach would be behavioral, then short-acting NRT, and a key point is more than 10 cigarettes per day. And after first trimester. Again, to go to Canadapt or Mother Risk for the guidelines. There's also a Smokers Helpline, there's a pregnancy, there's somebody with expertise around pregnancy as well. So again, it's not without risks using NRT, but less risk, the common sense approach, if the alternative is smoking and we're exposing the baby to 3,000 more chemicals, 3,999. And it comes down to this discussion between the healthcare provider and the woman and what she's comfortable doing. Oftentimes women, again, a generalization, they'll feel more comfortable smoking than using nicotine replacement. And Dr. Selby will often refer to this phenomenon as nicophobia, fear of nicotine. There's also evidence that it's safe to use, not again without risks, but relatively safe to use bupropion or Zyban in pregnancy. Again, this comes mainly from research, not just from smoking cessation, but looking at women taking antidepressants in pregnancy. And so far, the preliminary research indicates it's safe. If you go onto the Mother Risk site, there's a paper that will say one study showed that in the first trimester, women using this had an increased rate of spontaneous abortion compared to women who weren't taking bupropion, but not higher than the rates of spontaneous abortion in women using other antidepressants. Contraindications across the board, regardless if the woman is pregnant or not, for bupropion are eating disorders, seizures, alcohol dependency, MAOI inhibitors. So again, nicotine NRT is a second line option for individuals. The first line is behavioral counseling. ideally a combination of, if the woman's going to use NRT, combining that with behavioral counseling and looking at the support system. Depression during pregnancy is a common occurrence, so the use of Zyban or bupropion might be appropriate to treat both. Varenicline, we don't have any evidence to say that it's efficacious or safe, so we don't recommend that at this point. If we look at breastfeeding, we know that breastfeeding and relapse, sometimes the duration of the quit is only intended to be for the duration of the pregnancy, and the relapse, you could say, is planned. The other thing to flag, if we look at women's smoking status, they might have quit spontaneously in that first trimester. You might not even have had a conversation with them about their smoking because at the time of your first encounter, they've reported they're non-smokers. But if you do know that they were smoking previously, you might want to re-engage them in a discussion about smoking and maintaining abstinence, because the vast majority of women find it very difficult to maintain abstinence, even if the quit, they're hoping to maintain long-term abstinence beyond the duration of the pregnancy. So 50 to 75% relapse within 6 months postpartum. Other studies will say, again, at UBC, sometimes they'll quote studies saying that the relapse rate is as high as 90%. Again, understanding if this cessation is temporary or planned. We go back to breastfeeding versus bottle feeding. We touched on that earlier, that ideally breastfeeding is preferred regardless if the woman is using NRT or smoking. If she is still smoking, the ideal situation is that she doesn't smoke right before she breastfeeds or during breastfeeding, but can wait 2 to 4 hours after if possible. Some papers I've read have gone to the extreme and said even just if she smokes within that period to just pump out the milk and throw it out. That's not practical. It's extreme and probably not feasible for most women. But changing the clothes and washing the hands is highly recommended. Thinking about particulates and third-hand off-gassing, third-hand smoke, as the baby is nuzzling against the mother's shirt or in her arms, preventing exposure to those chemicals if she's still smoking, or in a smoky secondhand house, and breastfeeding, trying to make the home smoke-free. NRT does a little bit get into the breast milk, but at this point it seems safe according to the research, nothing to be worried about, and breastfeeding is still the best option. So, is pregnancy a teachable moment? I won't open this for discussion because I'm out of time, but it depends. It definitely can be, and it's definitely an opportunity to connect with women who tend to be highly motivated to quit smoking, a time where they might be most motivated to quit smoking, but doesn't necessarily mean that they are able to quit. The other key point is that depending on how you have these conversations and work with the woman, it can either work to increase her motivation to reduce or quit, or it might decrease. So let's talk about some exciting initiatives from the RNAO. And Catherine Wallace is joined us for this webinar, and she's with the RNAO Tobacco Cessation Program, and she is available for questions via chat. So I can read the slides, but I won't have very good answers to these questions. It would be improv. So the RNAO Smoking Cessation Initiative, supporting smoking cessation with pre- and postnatal women for this year, 2014 and 2015. So the RNAO is expanding its smoking cessation initiative this year and 2015 to include the specialized population of pre- and postnatal women and their families. And the objective is to build capacity for nurse practitioners, community and primary care nurses, and other healthcare professionals who work extensively with this population through the incorporation of smoking cessation best practices. The highlights of some of the activities to look forward to: workshops focusing on pre- and postnatal women to be held at sites across the province, no cost to participants. Participants will receive resources and quick kits for their clients, and to use an RFP process to select the host site. And what does the acronym RFP mean? Request for proposal, like a business plan for host sites. Highlight of project activities, so creating new resources for nurses and their clients, such as a wallet card with content developed by the RNAO, Mother Risk, and Smokers Helpline, expanding e-learning module series on smoking cessation, also to include pre- and postnatal women and their families. Another highlight, revision of the RNAO BPG, integrating smoking cessation into daily nursing practice, expanded focus on pre- and postnatal women and their families, with a monthly webinar series, presentations and guest speakers from Mother Risk, CAMH, OTRU, Ontario Tobacco Research Unit, SHL, Smokers Helpline, and other experts. And we have no time for questions, but if there's questions, definitely we'll stay on the line. I can stay on for a few minutes. And thank you, and I'm sorry that I didn't get through my slides as speedily as I planned.
So thank you so much, Stephanie, for the presentation. At this time, because we are running out of time, for those of you who do have questions that were not answered or you have more questions, please feel free to type them in the chat box. And what we will do is we will address them and email them back out, or the responses back out to you. So thank you again for joining.
And Catherine Wallace said, thanks, Catherine. Regarding the RNAO Smoking Cessation Project, you could forward your questions to Catherine Wallace at kwallace@rnao.ca.
Okay, so these are just a list of resources, and as a reminder, a link to the webinar evaluation will be sent by email, as well a link to the Learning Assessment 2, which must be completed 1 week after this webinar in order to receive your letter of completion. So please join us for our next Lunch and Learn webinar scheduled for Wednesday, May 28th. Thank you so much for joining. And for those of you who were wondering if you had received or if you could receive a copy of the presentation, you should have received an email with an attachment. So the email directed you to the link to the webinar, and the attachment is actually a PDF copy of the presentation. If, however, you did not receive that email, then please email Eleanor Ball-Banting, and the email address can be seen on the screen. So thank you again for joining, and we hope that you will join us at our next webinar.
Thank you. Yes, and please email the questions. I'm sorry that we ran out of time, but we will try to get back to every question.